Hello everyone, I'm Dr. Nikhil. So in today's ECG class, we'll be learning about atrial hypertrophy, ventricular hypertrophy and bundle branch blocks. So let's start off with atrial hypertrophy. So for any atrial pathologies, we study P wave, since P wave is nothing but atrial contraction. So for any atrial pathologies, we study P waves. So this P wave is best studied in lead 2. Lead 2 is the best wave to study P wave. Also sometimes we can take help of chest lead V1. So before going to atrial hypertrophy proper, we shall see what is the normal morphology of P wave. Normal morphology of P wave. So the normal P wave is a smooth upward wave in lead 2. In lead 2, normal P wave is a smooth upward wave which can be divided into two parts. The initial part and the next part. So P wave is divided into initial part and the next part, two parts. So basically the contraction of right and left atria cannot be measured on ECG because the time duration between two contractions is very minimal and this is not recorded on ECG machine. So in case of hypertrophy, this becomes evident and reflects on ECG. So for that we need to know the normal morphology of P wave. So as I told, it is divided into P wave is divided into two parts. The initial part is due to right atrial contraction and the next part is due to left atrial contraction. This is because the right atria depolarizes first. As SA node is present in right atria, so right atria depolarizes first, followed by left atria. But as I told, normally this is not deflected, whereas in case of atrial pathology, the morphology changes. So this is how P wave looks in lead 2. So now let's see in chest lead V1. So in chest lead V1, P wave is a biphasic wave with positive and negative deflection. So the first positive upward deflection is due to right atrial contraction and the next downward negative deflection is due to left atrial contraction. So this is the morphology of normal P wave. Now let's see how this changes in atrial hypertrophy. First, coming to right atrial hypertrophy. In right atrial hypertrophy, atrial musculature is thickened, so this causes increase in amplitude of waves in right atria. So this increased amplitude is reflected in ECG, producing a tall P wave. So this is most commonly seen in right atrial enlargement, which is also seen in lung diseases like cor pulmonale. Hence, this morphology of P wave is called as P pulmonale. So subjectively, this P pulmonale is identified by measuring the length of P wave, that is more than 2.5 small squares. Normally, the P wave is within, it is the length of the P wave, width of the P wave is 2 to 2.5 small squares, as well as the length of P wave is also 2 to 2.5 small squares. Whereas here, right atrial hypertrophy, the length increases, becoming more than 2.5 small squares, and this is called P pulmonale. This is in lead 2. In lead V1, chest lead V1, as I told, the initial part of the initial upward positive wave is due to right atria. So this changes is reflected in the upward wave, where the upward wave becomes prominent and enlarged, followed by small normal downward deflection. So here above the baseline wave is enlarged. So this is what is seen in right atrial hypertrophy. So there is P pulmonale, where the length of the P wave is more than 2.5 small squares in lead 2, and in V1 the above the baseline the wave is enlarged. Now coming on to left atrial hypertrophy. Left atrial hypertrophy. So here, as I told, the initial part is due to right atria. Initial part of the P wave is due to right atria, so that is normal. So now left atria is hypertrophied, so the electrical activity in left atria is more and the amplitude is more, producing an enlarged wave on ECG. So this produces a notching in P wave. So this morphology of P wave is called as P mitral, and this is subjectively measured by measuring the width. So the width is more than 2.5 small squares, and this is called P mitral. This is seen in lead 2. Now let's see what happens in V1. As I told, the upward wave is due to right atria, and that is normal, whereas downward wave, negative deflection downward wave, is due to left atria, and in left atria this downward wave is enlarged. So below the baseline wave is enlarged. So this is what we see in left atrial hypertrophy. So there is notching producing P mitral, where the width of P wave is more than 2.5 small squares in lead 2, and in V1 below the baseline the wave is enlarged. And then there's something called as biatrial hypertrophy, where both right and left atria is enlarged. Here the length of P wave is more than 2.5 small squares, as well as the width of P wave is more than 2.5 small squares. So this is about atrial hypertrophies. So now let's see some ECGs. So here look for lead 2. So lead 2, if you carefully observe, you can see the notching. There is notching over the P wave. You can see the notching, as well as when you see the width of the wave is more than 2.5. It is nearly 3 squares. It is nearly 3 small squares. So it is more than 2.5 small squares. And coming to lead V1, you can see the downward wave of P wave is enlarged. So the downward wave of P wave is enlarged in V1. So this is left atrial hypertrophy. left atrial hypertrophy. Again, see lead 2. So in lead 2, again there is notching over the P wave. The length of the wave is 2. So it is not right atrial hypertrophy. Whereas the width is 3 small squares. Width is 3 small squares. Along with this, in V1, the downward V1, the downward wave is prominent. The downward wave is prominent. So, this is again left atrial hypertrophy. In this ECG, you can see the P wave contour is enlarged. The length is more, whereas the width is within 2.5, almost 1.5 to 2. When you count the length, it is 1, 2, 3.5. So, the length is more than 2.5 small squares. So, this is an ECG of right atrial hypertrophy. Let's see, we are finished with atrial hypertrophy. So now let's study about ventricular hypertrophy. So to study ventricular hypertrophy, we have to study QRS complex, which is nothing but ventricular activity. So QRS complex is studied for ventricular pathologies and it is best seen in chest leads. So before going to ventricular hypertrophy, we'll see what is the normal QRS morphology in the chest leads. So the QRS waves has some particular pattern in which it follows from chest leads V1 to V6. So let's see how it varies. So normal QRS wave. So when you go from V1 to V6, there is certain changes occurring to the QRS waves. So basically the S wave is large in V1 and when it goes towards V6 it becomes small or absent. So this is the morphology of S wave, where it is large in V1, then as and when it goes towards V6 it becomes small and absent. In case of R wave, it is small or absent in V1 and when it goes towards V6 it becomes large. So this is the normal pattern of QRS complexes in chest leads V1 to V6. So now let's see how this varies in ventricular hypertrophy. Coming to first left ventricular hypertrophy. Left ventricular hypertrophy. So in left ventricular hypertrophy, this pattern of S wave and R wave changes from V1 to V6 is maintained. So pattern is maintained. Whereas the amplitude of wave is increased. Amplitude is increased. Along with this, there is T wave inversion. More specifically, it is strain pattern seen in V6. Strain pattern is seen in V6. So basically, inversion wave looks in this way. So this is T wave inversion, whereas this is strain pattern which looks like this. This Q, R, S, it has something like this. So this is the strain pattern which is seen in ventricular hypertrophy. So in left ventricular hypertrophy, the pattern is maintained, amplitude is increased, and T wave inversion or strain pattern is seen in V6. So there is some objective criteria to say the amplitude is increased. So the diagnostic criteria for left ventricular hypertrophy, this is based on Scholar-Leon criteria. Scholar-Leon criteria. So the various criterias are: first, the amplitude of S wave in V1 or V2 chest lead is more than 25 mm or small squares, or amplitude of R wave in V5 or V6 is more than 25 mm or 25 small squares. So as I told, the normal pattern is maintained. So S wave is large in V1 and R wave is large in V6. So here we see S wave in V1 or V2 which is more than 25, or amplitude of R wave in V5, V6 which is more than 25. So there are certain other criterias. The other criteria is R wave in V5 or V6, you sum it up with S wave in V1 or V2, and if this is more than 35 mm, then that is also diagnostic of left ventricular hypertrophy. The other criteria is R wave in AVL more than 12 mm, or any R wave, you sum it up with any S wave if it is more than 45 mm. So these are the criteria where amplitude of S wave in V1 or V2 is more than 25 mm, amplitude of R wave in V5, V6 is more than 25 mm, or R wave in V5, V6 when you sum it up with S wave in V1, V2 it is more than 35 mm, or R wave in AVL is more than 12 mm, or any R wave and any S wave you sum it up it is more than 45 mm. So these are the diagnostic criteria for left ventricular hypertrophy. So along with this, left ventricular hypertrophy is usually associated with left axis deviation. So oftenly this is associated with left axis deviation. So this is about left ventricular hypertrophy. Now let's see what is there in right ventricular hypertrophy. So right ventricular hypertrophy, the pattern is altered. Pattern is altered where R wave is prominent in V1 or V2 and S wave is prominent in V5 or V6. The normal pattern was S wave being large in V1 and small S wave was small in or absent in V6, whereas R wave was large in V6 whereas it was small and absent in V1. Here the R wave becomes prominent in V1, V2 where it was small, and S wave becomes prominent in V5, V6 where it was small normally. So along with this, T T wave inversion or strain pattern is seen in V1. So now let's see what is the objective diagnostic criteria for right ventricular hypertrophy. So even this is based on Scololion criteria. So first one is R wave in V1 or V2 is more than 7 mm or 7 small squares, or S wave in V5 or V6 is more than 7 mm or 7 small squares, or R wave in V1 plus S wave in V6 is more than 11 mm. So the diagnostic criteria is R wave in V1, V2 more than 7 mm, or S wave in V5, V6 more than 7 mm, or R wave in V1 with S wave in V6 is more than 11 mm. So this may or may not be associated with axis deviation. Axis deviation, if it is present, it is always right axis deviation. If it is present, it is always right axis deviation. So let's see the differences. Left ventricular hypertrophy, right ventricular hypertrophy. So the first one is in left ventricular hypertrophy, pattern is maintained, amplitude is increased, whereas in right ventricular hypertrophy, pattern is altered. Then T wave strain pattern is seen in V6, whereas T wave strain pattern is seen in V1. So in left ventricular hypertrophy, there is left axis deviation, and right ventricular hypertrophy may or may not be associated with right axis deviation. So this is how it looks in ventricular hypertrophy. Now let's see few ECG images. So ECG images. So V1, in V1, S wave is prominent, and in V6, R wave is prominent. So S wave is prominent in V1 and R wave is prominent in V6. So it is definitely not right ventricular hypertrophy. Let's see, calculate the length of the waves, amplitude of waves. Here for S wave it is 1, 2, 3, 4 big squares plus 1 small squares. So each big square has 5 small squares. So 4 into 5 it is 20 plus 1 small squares it is 21. So still within 25 small squares. Let's see V2. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 big squares. So 9 into 5, 45. So it is more than 25 small squares in V2. S wave is more than 25 small squares in V2. So it is right ventricular hypertrophy. So let's see R wave in V6. 1, 2, 3, 4, 5 plus 1 small squares. 5 large squares plus 1 small squares. 5 5s are 25 plus 1 small is 26. So R wave is more than 25 small squares in V6. So this is left ventricular hypertrophy. Left ventricular hypertrophy. Now let's see axis deviation. So as I told, to see axis deviation, we have to see two perpendicular leads. Usually it is lead 1 and AVF. As I told in the earlier classes, it is seen in two perpendicular leads. Usually we take lead 1 and AVF. So lead 1, it is positive waves. So as I told, positive wave of lead 1 would be here. Then AVF has negative waves. So negative wave of AVF would be here. So it is involving this quadrant. So this quadrant is an overlap. This quadrant is an overlap between normal axis and left axis. So as I told in previous class, below minus 30 is normal axis and away from minus 30 is left axis. In such condition, as I told, we have to see lead 2, where if lead 2 is a positive wave, then it is normal axis. Here lead 2 is negative wave, so current is moving away from the lead 2, so it is left axis deviation. So this is an X-ray, this is an ECG of left ventricular hypertrophy with left axis deviation. So we'll see next ECG. So here, and one more thing, see for strain pattern. As I told, V6 in left ventricular hypertrophy, strain pattern is seen in V6. So you can see the strain pattern in V6. So T wave strain pattern is present in V6. So this next ECG here in V1 R wave is prominent. R wave has become prominent in V1, and V6 S wave is prominent. V6 S wave is prominent. So the pattern is altered. So this is right ventricular hypertrophy. So now let's count and see the boxes. So here it is 1, 2 large squares plus 3 small squares. So 2 5s are 10 plus 3 small squares is 13. So R wave is more than 7 mm in V1. So it is right ventricular hypertrophy. Let's see S wave. S wave is 1 large square plus 2 small squares. So it is 7, still within the limit. Let's see in V5. It is 1 large square plus 3 small squares plus 2 small squares. So it is 5, 6, 7, 8, 9, 10. So S wave is more than 7 mm in V5. So it is diagnostic of right ventricular hypertrophy. So coming to the strain pattern, you can see the strain pattern in V1. So strain pattern is present in V1. Strain pattern is seen in V1. So it is again a criteria for right ventricular hypertrophy. Now let's see axis deviation. Again, to see axis deviation, we'll see lead 2 and AVF. So first one, lead 1, it is a negative wave. Lead 1 negative wave will be here. Then coming to AVF, AVF is a positive wave. So positive wave will be negative wave of lead 1 and positive wave of AVF. So it is in this quadrant, which is right axis deviation. So this is right axis deviation. So this is an ECG of right ventricular hypertrophy with right axis deviation. So this is how we interpret hypertrophies, ventricular and atrial hypertrophies. So let's see why does the axis deviation occurs in this way in both. Why there is left deviation in left ventricular hypertrophy and right deviation in right ventricular hypertrophy. So for this, this is the axis VVF. So this is the normal heart. So this is the axis of the normal heart where the vector or the axis is in this direction. So this is normal axis. So from minus 30 to plus 90, this is the normal axis of the heart. Now let's see what happens in hypertrophies. So in left ventricular hypertrophy, the left ventricular muscle is enlarged. Left ventricular muscle is enlarged, causing increased electrical activity in the left ventricles. So the vector is pulled towards the left ventricle, that is in the left side, producing left axis deviation. In case of right ventricular hypertrophy, the right musculature of the heart is increased, producing increased activity in the right ventricle, that is towards the right side of the heart, producing right axis deviation. So this is why there is left axis and right axis deviation in hypertrophy. In hypertrophies, the axis is pulled, the vector is pulled towards the site of pathology. Whereas in case of MI, because there is muscle necrosis, the activity on the site of my MI is reduced. The electrical activity on the site of MI is reduced. So in such case, in MI, the cardiac vector is pushed away from the site of pathology. So now coming on to the last topic for today, that is bundle branch blocks. Bundle branch block. So normally the ventricle muscle has left and right bundles. So the left side is activated by left bundle and right side is activated by right bundle. So in case of bundle branch block, say for example, there is block in the left bundle. If there is left bundle, only the right is active. So what happens is, now the right bundle activates the right side of the ventricle, following which the same right side will activate the left side of the ventricle. Since the left bundle is blocked, the right bundle will have to take over, and after activating right ventricle, it is activating the left ventricle. So normally what happens is, both the ventricles are activated by its own bundle branches. So and there is very minimal delay in the activation of both the things. So the QRS complexes of both right and left is superimposed on each other on ECG and cannot be detected separately. Whereas in this condition, since the right is activated, following which the right itself will have to activate the other the block side. So this delay is shown up on the ECG. So after activating right side, this is the R wave of the right ventricle. After activating the right side, the same right side will have to activate the left side. So we get something as this. The morphology of QRS is changed to this. So this is called with various names such as RS, R dash pattern, or it can be called as RS, R dash pattern, or it is also called as M pattern, as it looks like M. It is also called as rabbit ear pattern, It can also be called as N pattern, since some of the waves looks like N instead of M, so it can also be called as N pattern. So now let's see. So this is the changes which is seen in few leads. So the reciprocal leads will have reciprocal changes. So reciprocal leads will have reciprocal changes called as W pattern. So W pattern is seen in reciprocal leads. It can be W pattern, or it can be a curved S pattern, where curved S pattern. So let's see how these waves are seen in how we shall identify whether it is right or left bundle branch blocks. So right bundle branch block and left bundle branch block. So M pattern is seen in V1. M pattern is seen in V1 in right bundle branch block, whereas it is seen in V6 in left bundle branch block. The reciprocal change, that is W pattern, is seen in reciprocal leads. So W pattern is seen in V6 in right bundle branch block, and it is seen in V1 in left bundle branch block. So these are the changes which we see in right and left bundle branch blocks. Along with this, the left bundle branch block is usually associated with left axis deviation. And if left bundle branch block should have ST depression. It should have ST depression and T wave inversion. If there is no T wave inversion, then it is suggestive of MI. With left bundle branch block. So left bundle branch block is always associated or usually associated with left axis deviation, whereas right bundle branch block is usually with normal axis. In certain scenarios, it is associated with axis deviation. Let's see what it is. So if right bundle branch block is associated with right axis deviation, then it is left posterior fascicular block. And then if right bundle branch block is associated with left axis deviation, then it is left anterior fascicular block. So these are the changes seen in right and left bundle branch. So coming again, right bundle branch block, there is M pattern in V1 and W pattern in V6, and usually it is a normal axis. In case it is associated with right axis, it is left posterior fascicular block, and if it is associated with left axis, then it is left anterior fascicular block. Then coming to left bundle branch block, it is M pattern in V6 and W pattern in V1, and it is usually associated with left axis deviation. So now let's see the ECGs. So here V1 there is M pattern or N pattern. This is more of like N pattern. So M pattern or N pattern is present in V1. And if you carefully observe V6, you can see this W pattern. You can carefully see this W pattern in V6, also in V5. So there is M pattern in V1, M pattern in V1 and W pattern in V6. So this is right bundle branch block. Right bundle branch block. So now let's see the axis. Let's see axis. So here lead 1 has both positive and negative waves, but more of it is positive wave. So here AVF is a positive wave. So it is here. So this is normal axis. This is normal axis. So this ECG is of right bundle branch block with normal axis. Right bundle branch block with normal axis. Now coming to next ECG. Next ECG also you can see this M or M pattern in V1. Then when you see V6, there you can see this notching in the S wave forming W pattern. So this is W pattern V6. This is again right bundle branch block. Now let's see the axis deviation. So lead 1 has both positive and negative waves, but predominantly it is a negative wave. So it is here. AVF is a positive wave. In AVF it is a positive wave. So it is here. So this is right axis deviation. Right axis deviation. As I told, this is a right bundle branch block with a right axis deviation. So this is left posterior vesicular block. Left posterior vesicular block. Next ECG. Again in V1 you can see there is M pattern. So M pattern is seen in V1. And there is this curving S wave pattern. Curved S wave pattern. As I told, there is curved S wave pattern in V6. So this is again right bundle branch block. So now let's see the axis deviation. So there is V1, there is both lead 1, there is both positive as well as negative wave, but predominantly it is positive than negative. So it is here. Coming to AVF, AVF is also has positive and negative wave, but predominantly it is negative. Predominantly it has negative waves. So it is here. So the vector comes in this quadrant, so it is left axis deviation. So right bundle branch block with left axis deviation, so it is left anterior fascicular block, left anterior fascicular block. So here V1, there is no M or W pattern. There is no M or W pattern. Whereas in V6, you can see the M pattern. So M pattern is present in V6. Also M pattern is present in V5. So this is a left bundle branch block. So now let's see the axis deviation. So lead 1 is positive wave. Lead 1 is positive wave. AVF is negative wave. AVF is negative wave. So the vector is in this quadrant, which is left axis, which is left axis deviation. Left axis deviation. So this is an ECG of left bundle branch block with left axis deviation. So this is how we interpret ECGs in hypertrophies and bundle branch blocks. Thank you.